So our presentation today is about building the pharmacy workforce for antimicrobial stewardship, especially here in the state of Nebraska. We really wanted to bring this topic forward because there is such a need for pharmacists to become involved and interested in antimicrobial stewardship. As mentioned, I just joined the team at Nebraska Medicine this last year, and in the search for my replacement as a stewardship pharmacist at my former hospital, it was really difficult to find people that had any sort of background in training in stewardship. And so we just wanted to share some different ways that pharmacists can become involved in stewardship today. We have no disclosures for the presentation today, and our objectives are to first appraise the need for increased pharmacist training to participate in antibiotic stewardship activities, and then secondly, to assess various strategies and resources to grow pharmacist involvement in antibiotic stewardship programs in Nebraska hospitals. So I'll begin with kind of an introduction state of the union for antimicrobial stewardship pharmacists. So I want to start out talking about a little more of a description of what it really means to be an antimicrobial stewardship pharmacist. I think being an antimicrobial stewardship pharmacist is a unique role because it combines a lot of direct patient care activities and bedside patient care with a more leadership role with administrative and team building opportunities as well. The antimicrobial stewardship pharmacist is typically the one doing the day-to-day heavy lifting of patient care, doing patient rounds, providing drug information to the team, and then facilitating things like guidelines, medication use, like formulary additions, and lab test utilization. There's also a heavy administrative component to this position. The Joint Commission made this a requirement for hospitals in 2017, and so there's a lot that goes into regulatory preparedness. Performance improvement and quality is kind of the name of the game with stewardship, and so there's a large component there as well. And then data analysis using some of those metrics that we talked about earlier with the NHSN AU/AR option. The pharmacist is typically leading that. And then informatics as well, getting IT resources and technology built so that's very user-friendly for your facility from an antimicrobial stewardship standpoint. There's also a lot of team building. You're really kind of the team lead for stewardship, which involves a bunch of different interdisciplinary professions, including infection control, bedside nursing, physicians, and then executives in your facility as well. So as mentioned before, stewardship programs became a requirement for accreditation by Joint Commission in 2017 and a condition of participation for Medicare and Medicaid services. And so that regulatory requirement, as Chris kind of said earlier, was a little bit of a nudge, and then this became the shove that led to the rapid expansion in number and scope of stewardship programs across the entire country. So in 2014, which was around the time that I started doing antibiotic stewardship, only 41% of hospitals in the country said they were meeting all 7 core elements of the CDC's antimicrobial stewardship programs. But in 2021, it was all the way up to 95% of hospitals in the country reporting that they had met all 7 core elements for antibiotic stewardship. And so we've seen a rapid expansion in the number of hospitals providing many, many more services related to antibiotic stewardship, and it's really just outpaced the number of infectious diseases trained pharmacists that are available to fill those roles. So this is the data out of NHSN from the annual survey that hospitals complete every year, where they voluntarily tell NHSN if they're meeting a core element or not. And so you can see the same trend nationwide in 2014 and 2015, where programs are really starting to implement the core elements. And then in 2021, which is the most recent year published, Nebraska was meeting 86% of hospitals in Nebraska were meeting all 7 core elements. And while this sounds like a very high percentage, it's actually 9% lower than the national implementation rate. And we're, I believe, in the lowest, like 10 states in the entire country for number of hospitals meeting all 7 core elements. So there really is a need for expanded services for antibiotic stewardship here in Nebraska. Every year, the American Society of Healthcare Pharmacists does a national survey of hospitals throughout the entire country, kind of asking where are you staffing pharmacists in your hospital on a day-to-day basis. And so this is kind of a narrowed down chart. I chose ID and stewardship, critical care, med surg, and oncology pharmacists. And this is percentage of hospitals that replied to the survey that have a pharmacist assigned to these specialties at least 8 hours a day, 5 days per week. And so I think you can see in hospitals with 300 or more beds across the country, it's basically become standard of care that there is always a stewardship pharmacist assigned for patient care. But I think it is actually encouraging, even though the smaller hospitals look like lower percentages. In those under 50 staffed beds, we see almost a quarter of them do have some sort of stewardship pharmacist available still. And so I think this is a small number, but a good improvement over years past. When we look over a 10-year span of how pharmacist staffing in all of these hospitals is changing, we see a precipitous jump around that time of 2017 when the Joint Commission started requiring antimicrobial stewardship programs in hospitals. And so we see from 10 years ago in 2011 up to 2021, a 27.2% increase in hospitals that are staffing as antimicrobial stewardship pharmacists at least 8 hours a day, 5 days a week. And so if you look again at those same other subspecialties of pharmacy, med surg, critical care, and oncology, we see that ID and stewardship is on pace with some of the more or some of the other specialties in pharmacy as far as increase in amount of staffing. Another realm where ID pharmacists and stewardship pharmacists' presence is really growing is in outpatient clinic operations. So in this situation, we changed our comparative specialties to ambulatory care, anticoagulation, and pain and palliative care because those are more commonly seen in the outpatient realm as opposed to critical care and oncology. But we do see infectious diseases becoming more and more common to have an ID pharmacist available in the larger health systems. And this was only started to be measured 3 years ago. And so we see a growth in this realm as well. I thought it was interesting when we look at the trend. This one was only a 7-year trend as opposed to a 10-year trend. And we only see infectious disease represented here since 2018 because that's when they added it to the survey. But in our colleagues in pain and palliative care, it took them 7 years to see the same amount of increase in pharmacist presence in outpatient clinics as infectious disease pharmacy saw in just a 3-year span. So it is slowly growing in a relatively new service, but a good opportunity to get pharmacists involved and shows a need there as well. So this kind of depicts every stewardship pharmacist's perspective of the pandemic, I will say. But I think instead of focusing on this burnout as depicted in the little cartoon here, I think the pandemic really opened a lot of people's eyes to the importance of antibiotic stewardship pharmacists. And this becomes a pivotal point in which we can advocate for increased services. So Dr. Langford gave an entire very good talk about this today, so I won't belabor it too much more, but we're just reinforcing that turning resources from stewardship during the pandemic away from stewardship, particularly in the pharmacist realm, we're seeing an increase in resistant infections and overuse of antibiotics. A survey that was done of stewardship pharmacists that were working during the pandemic in 2021, which I guess is a little bit premature because they still had a couple years to go at that point, showed there was just an increase in FTEs in the whole hospital staffing. So the hospitals were hiring more FTE pharmacists to handle the increased workload, but they also saw an 18% decrease in stewardship-specific FTEs. Stewardship pharmacists also that were reporting working those 8-hour days, 5 days a week, 82% of them said their hours had increased from 8 hours to 9 to 11 hours. And then as far as impact on stewardship activities itself, we see that 99% of survey respondents felt that COVID had some negative or a negative effect on their ability to do antibiotic stewardship. We saw a lot of redeployment. 57% of survey respondents said they were redeployed to non-antimicrobial stewardship specific activities for over 50% of their duties. And I think that's just because what was needed to be done, listed over here on the side, aligned very well with what stewardship pharmacists are good at doing. They became the communicators, the guideline writers, the drug shortage managers, the vaccine rollout experts, and had to handle a lot of the misinformation that was coming out. So in a more positive light, I think, like I said, this is a pivotal time for antimicrobial stewardship pharmacists, and we have a good opportunity to kind of reimagine the future of stewardship and refocus. So primarily, a lot of the ways that we're going to recruit stewardship pharmacists to the profession is going to require significant support from leadership. This slide was presented by Dr. Monica Mahoney at the SHEA Spring meeting in 2023 as part of an entire session of how we can recommit every different ID specialist, no matter what their role, physician, pharmacist, infection preventionist, to antimicrobial stewardship following the pandemic. And so these are just some of the ways that were mentioned during that presentation that we can advocate for stewardship pharmacists. And so with that, I will turn it over to Scott. For the remainder of the session, we have 3 other pharmacists that practice stewardship here in the state of Nebraska. We all have very different training routes to our position. We have very different day-to-day job responsibilities and perspectives on the profession. And so I just wanted to give them an opportunity to share their experiences in stewardship.
Thank you, Jenna, for that smooth transition and for organizing this great conference. It's really been back-to-back excellent speakers, and my job here is to help close it out by giving some of the educational landscape and what we're doing to train students and residents as antimicrobial stewards, and then we'll hear from several of our workers that are in the stewardship space that haven't done a traditional path of training. Also, with this large aisle here, I was wondering whether the bride's side or the groom's side would have more people on it at the end. I think the groom's side won, and maybe stick around and we'll see who gets married afterward. All right, so from a curriculum standpoint, I am a faculty at the University of Nebraska, and we have about 60 students each year that get a little bit of stewardship education, but I wouldn't say we're training them to be experts, as this is an entry-level degree. We're covering a lot in our infectious diseases therapeutics course. It's in the fall of their 3rd professional year. I talk about stewardship with them, explain my role, give them some of the principles in the introductory classes but really they're being overwhelmed by all the microbiology, the bugs and the drugs, we like to say, and the place in therapy during the clinical therapeutic session. We talk about de-escalation and IV to oral, but it's more in the broader sense. They do get a little bit more application in their pharmacotherapy labs. They practice pharmacokinetic cases and therapeutic drug monitoring notes. They also get a case with microbiology results and looking at that, trying to interpret it. They have to present their recommendations in a mock rounding situation. We use the pharmacy residents as the attending physicians and the teams that students have to explain why they think the doctor should change antibiotics. These are brief, but I think meaningful steps towards them understanding stewardship, but it really takes more practice and more expertise. They have a lab on vaccine hesitancy as well, and drug interactions in the outpatient setting, and how, no matter what role of pharmacy you're in, you're probably going to deal with anti-infectives and be able to provide some advice, because prescribers really don't know everything about the pharmacology and the drugs, and look for pharmacists now, for advice on those agents. We don't have an infectious disease specific elective or antimicrobial stewardship focus. There is a HIV elective that several of the faculty offer, but other schools that I've been a part of. I have taught an elective in infectious diseases. The University of Wisconsin has one similar to that, and they've even designated a path of distinction, which is a pretty cool idea where you're already taking required therapeutics classes that involve antibiotics or microbiology, and they have an elective course, and then if you take a experiential rotation and do a small research project, you can get this awarded on your diploma that you are you trained in stewardship from an education standpoint. So it's not a surprise that students that go on to do that experiential rotation, the APPE or Advanced Pharmacy Practice Experience as they're called, they feel more confident in their knowledge of infectious diseases. This was proven in a study, but I think it's intuitive, and we all recognize that getting practice with basic microbiology, interpretation, using those stewardship principles and selecting therapy, looking at cultures and susceptibilities, and then making recommendations to de-escalate therapy are really the goals of antimicrobial stewardship. So there are opportunities to practice that. Unfortunately, our state doesn't have a lot of specific infectious diseases rotations for students to take. Right now, in fact, the Med Center is the only one offering them. After we stole Jenna from Faith Regional, they haven't been able to offer an ID-specific rotation, but with her replacement coming on board this summer, they have committed to taking students in the following year. I know a lot of you are involved in stewardship, where you're learning more here, and I think other rotations can also have benefit without specialization. So some of the things that you could involve students with at your hospital or health system where you work, doing things like IV to oral conversion is a method of stewardship, and renal dose adjustments, having protocols in place or talking to providers, giving education on best practices, having them look at current guidelines, comparing them to order sets, and even helping develop new clinical pathways. These are ways students can get practice and build their confidence, but also help you out in your day-to-day activities. After their PharmD, students can go on to do postgraduate residencies. These are one-year experiences at hospitals and health systems. So we call them PGY1, the first year, mainly clinical pharmacy and leadership and communication skills that they're building, similar to what Jenna described as really being necessary for the antimicrobial stewardship pharmacist. They'll do rotations in a variety of different specialty areas and general medicine, intensive care units, even ambulatory clinics and emergency medicine facilities. They have to complete a quality improvement project, which goes along with those goals of antimicrobial stewardship. Of course, they could do it in other areas as well, but getting that practice under mentorship. Then there's also a second year option where they can specialize. As Jenna mentioned, I'm the program director for the postgraduate year 2 infectious diseases specialty residency. There, I only take one resident a year, which is pretty typical of all specialty programs. They will take 4 months of antimicrobial stewardship, 3 months with the general infectious diseases service, 2 months on immunocompromised ID services, another month of orthopedic infectious diseases, a month of outpatient parenteral antimicrobial therapy, longitudinal HIV clinic, and their quality improvement project as well. So really digging into ID and antimicrobial stewardship. A few of those residents can go on to complete fellowships that are more focused on research and faculty positions. But really the PGY1 residency is the most common path, and it was the core for antimicrobial stewardship training if they don't go on to specialize, and usually those second year residents are going to larger medical centers and health systems. This graph is from the American System of Health System Pharmacists, the PGY1 General Pharmacy Residency Match. The red line is the number of applicants at the top, and the first thing you notice is that it was very high and increasing before a decline during the pandemic, and the blue and green lines in the middle are the number of programs and positions, and the actual availability of residencies. So the demand far outweighed the supply of programs. So there are always 1,000 to 2,000 students that sought out a postgraduate year one residency and were not successful. So there are definitely residents out there interested in this, but it is also a lot of work for hospitals to run the program, so that supply hasn't, or the supply hasn't kept up with the demand. Now that the pandemic kind of made people reevaluate or the wanting extra training, or maybe it was just difficult to get out and look for sites, that has gone down. But I guess the point is that there are still a lot of interested candidates out there, and even the ones that didn't get a residency can still be good students and good pharmacists with the proper mentoring. The infectious disease residencies are just a subset of those. First-year residents will go on to do it. So there was about 160 candidates for around 140 positions. So you can see that also with the pandemic, that demand dropped off to a point where there were actually more positions than candidates in 2021. This is something, there's always still good candidates out there after the match, that haven't been able to find the right specialty residency position. Those candidates are looking for jobs and want to dedicate themselves to learning more about infectious diseases with on-the-job training. So that brings me to the next transition, where Danny Schroeder is going to talk about his path to becoming an antimicrobial stewardship pharmacist.
Okay. Hi, I'm Danny Schroeder. I'm the clinical pharmacist practitioner at Nebraska Medicine Bellevue, and I also am the antimicrobial stewardship pharmacist there. And I'm going to talk a little bit about my pathway and then some other pathways that are non-traditional to get ID training in antimicrobial stewardship. So how did I get here? As Jenna mentioned earlier, in 2017, the Joint Commission had some new ASP standards. And so they required some on-site stewardship personnel. And so Nebraska Medicine at the time had a stewardship program. They just didn't have anybody on site at Nebraska Medicine Bellevue. And so I was approached to spearhead that. I didn't have any formal ID training, but I had been on board at Nebraska Medicine Bellevue since 2012. So I was the most experienced staff pharmacist. I didn't have residency training and didn't have the pleasure of doing API rotation in infectious diseases with Scott or anybody who was at Nebraska Medicine at the time. But what I did have was some hands-on training at Nebraska Medicine. So I got to spend a couple days with Scott and the ID team at Nebraska Medicine rounding. Got to see some and learn some good communication skills for antimicrobial stewardship, and got to learn some good antimicrobial stewardship pearls to take back with me to Nebraska Medicine Bellevue. Also started with some assistance from ID physicians twice a week. When I first started reviewing patients, this was very helpful for me because it was pretty new to me, and they were able to give me a lot of knowledge and help me build my knowledge base to perform bigger and more impactful interventions with stewardship. Also dedicated time for stewardship. I know this can be pretty difficult to find, but having that dedicated time, if it can be built into a job description as well, can help you get that time to learn more and be able to perform good interventions. And my cheesy answer, hard work and passion for patient care and stewardship. I think it was seen that I performed very hard work and that I had a very good passion for patient care at the time. And I think everybody here has that same passion and that same desire for patient care and stewardship, and that's really all you need to get started. So what do? I have an hour a day for my stewardship activities. Listed there are things that I target. It's built into our EHR, so it makes it easier for me to find these patients that need interventions. But top priorities being Staph aureus bacteremia and rapid blood pathogen panel results, among others listed there. Like I had also talked about earlier, I have 30 minutes twice a week to discuss patients with an ID physician. This is built into my schedule and built into his schedule as well. So it's, again, dedicated time for us. And then I do a lot of prospective audit and feedback, which was mentioned multiple times today, with handshake stewardship. Handshake stewardship being face-to-face contact with physicians or providers. And having that helps build the relationships, helps build trust with providers. So then it helps you make more impactful interventions and will be better received, typically, the more trust that you have with those providers. And then I also do Pharmacist education specific to Nebraska Medicine Bellevue. We recently rolled out a newer software for vancomycin dosing based off AUC, so I fielded a lot of questions from the Bellevue staff regarding that. I've also sent out little pearls emails to the staff about when there's new guidelines that come out. So one example would be the Heck Yes organism, so AMP-C producing organisms. So when the IDSA released new guidance on treatment recommendations for AMP-C producing organisms, I sent out a reminder email about that. So how can you get here? So there's lots of different pathways. My pathway was unique. I'm sure a lot of other people have their own unique pathways as well. But one way is completing an antimicrobial stewardship certificate program. There are 3 different programs that are offered. The Society of Infectious Diseases Pharmacist, or SIDP, offers one. Making a Difference in Infectious Diseases, or MAD-ID, makes one. And the Society for Healthcare and Epidemiology of America, or SHEA, has one. Also collaborating with local experts if possible. Like I said, my time with the infectious diseases physicians and continued time with them, I've learned a ton, and it's really helped me build my abilities in stewardship. So we'll talk a little bit about the 3 certificate programs here, though. So the SIDP certificate program, it consists of 3 different parts. So there's a foundational knowledge component, strategies for implementing stewardship in various practice settings. So these are the first 2 parts. They are on-demand self-study webinars. And once those are completed, you do a practice-based project to demonstrate the mastery of the concepts that you learned from parts 1 and 2. Needs to be completed within a year. And there's a new and improved certificate program that SIDP is working on now that should be released soon. The cost for it is $600, but it previously was $750, and it does include a free membership for a year. MAD-ID's basic training program is a 4-part program, overall pretty similar to SIDP's. Part 1 and 2 covers the basic knowledge and skills, and then part 3 is an elective section, so you can pick 3 electives that interest you, or you can do all 7. There's 4 additional that you can pay extra for. And then part 4, again, is a more practical component that needs to be completed within 12 months of completing part 3. There's also some optional quarterly teleconferences that you can take part in to discuss the program and other things with faculty and other learners. The cost for that program is $500. And then the SHEA Antibiotic Stewardship Training course is a course that's built into the SHEA Spring Conference. There's pre-work prior to the conference that has 5 online modules, and then there's 15 live sessions during the conference, which is a 3-day conference. And so the cost for this one's a little bit more since it is a full conference, and the cost varies depending on member status and time of registration. And both physicians and pharmacists can complete this course. Some other resources that you can use to help build your stewardship knowledge in your program. There are a bunch of publicly available resources. So the CDC offers antimicrobial stewardship modules. UNMC's stewardship guidance is freely available. Stanford and Michigan as well. There's, I'm sure, countless other ones that you can find as well. So it's, don't have to reinvent the wheel if you're starting to try to build a protocol for your facility. You can use some of these ones that have already been built and tailor them to your facility. And then I like to plug Twitter ID as well. So Twitter ID is a great community. I've learned a lot from looking at that. There's providers from all over the country, all over the world that post interesting topics in ID. Here's some other resources. These are paid resources. In the interest of time, I'll skip to the next slide here. Last thing I wanted to touch base on was this survey that was sent out by this group of pharmacists listed here. It was a nationwide survey to ACCP members in certain listservs, and they wanted to figure out how pharmacists with formal antimicrobial stewardship responsibilities prioritize their time, and how those with non-formal responsibilities, what kind of interventions that they partook in. And this is a graph of what they found. On the middle left column there is the pharmacists with formal ID training and certification, and then the middle right column is those without formal ID training and certification. And these were the pharmacists that said that they had formal roles in stewardship. And as you can see, they're the ones with formal training spent 70% of their time in total direct stewardship activities, while the ones with no formal ID training or certification spent 35%. And on this slide here, this shows the stewardship activities that were performed. And the middle left column is those with formal responsibilities, and the middle right is those without formal responsibilities. And those without formal responsibilities performed basic interventions for the most part, and those with the formal performed basic as well as more intermediate and advanced interventions. And I think what this can tell us is if we can get those with formal responsibilities more education, they can perform the more advanced interventions if they can disseminate that knowledge to their pharmacists that don't have the formal responsibilities, get them to do more basic interventions, and that will free them up to do the advanced interventions. And with that, I will pass it on to Anthony. Thank you.
Thanks, Daniel. I am so thankful to be here and quite humbled, actually, to be a part of this panel and this group overall. I've learned a lot today. Fantastic speakers. It's been wonderful. So I'm only sorry that one of your final impressions for today is to be left with me. But as it is, I'm going to go back here. So my focus of the talk is really towards those critical access hospitals, the smaller facilities that don't have their local ID expertise, and how you can partner with them, with someone to help manage that. Before I do that and kind of get into those specifics about what that looks like and the benefits that we've gotten from that, I want to give you a little bit of a background about community hospital and our antimicrobial stewardship journey through the years. Kind of started back in, I started collecting MDRO surveillance data in 2010. And then the next year I added on an antibiotic utilization report, and believe it or not, yeah, I did that manually. I wouldn't recommend that. There's a reason that NHSN doesn't let you do that. It's a lot, and you need technology. But the following year, I did a local antibiogram, and one may ask themselves why, because I certainly asked myself when I was putting this together, why did I do that? I had to do some reflection and kind of go back, and actually I was prepping and studying for a certification, my board certification in pharmacotherapy, and I think one of those modules as I was taking it just kind of led me in this direction where I saw some value in some of these things, and I started gathering this data. But I gathered it in 2013. Now I'm producing these annual metrics, and I'm giving myself a pat on the back saying, yeah, we're doing stewardship. And we weren't doing stewardship. I had some data, but then it was already mentioned Joint Commission. We are not Joint Commission certified, we're DNV, but they came out with their requirements. I saw the critical access hospital core elements from the CDC, and really started looking into those things and realized, yeah, we've got a long ways to go. As a side note, in 2017, our lab stopped doing micro, so we lost our ability to produce our local antibiogram. I also threw in the towel on doing the antibiotic consumption reports because it was just too much. I had to give it up. But it was at that time we got the core elements from the CDC. I was looking through those. It was overwhelming, and I thought, okay, well, let's start. What are we going to do? And we started with some of the low-hanging fruit. I, myself, went through the SIDP certification course. I encouraged the other pharmacists with me to go through that course. And through that and the projects that are part of that course and integral to that, we started putting out some of these things like a restricted antimicrobial list, a renal dose adjustment policy, got it into our job descriptions, put it in there. And then there's a mistake on this slide. It said we got the ASAP program came on site and did an assessment in 2020. That's not right. I don't know why I put 2020, other than to say, you know, decades from now when we're asked by our kids what happened when, the standard response is going to be 2020 for everything. I don't know. But that's wrong. We actually had their assessment several years prior to that. But they came on site, kind of gave us great feedback, good feedback, encouragement to continue doing what we were doing. And yet even through all of that, there was still this, all of our pharmacists had gone through the certification course, but when you look at those core elements, there was still that kind of nagging element. Do we really have expertise? Do we really have the expertise we need to make meaningful changes for stewardship? And I didn't think we did. And so we did reach out and partnered and started getting into a stewardship partnership with a bigger facility that could provide us that expertise. I'm not going to spend a lot of time on this slide or the next one. Actually, it matches very much, it resembles some of the material that was out front earlier. It's basically the core elements. It's how I kind of I digested them, put them on a spreadsheet, and put in comments to them, turned them green as we went through them. But as you can see, we still have work to do, and we're never going to be done. There's always going to be work that can be done. But anyway, what it looks like for us and some of the benefits we've received. So we have a scheduled daily call. It's usually mid-morning, and either myself or one of the other pharmacists, we go through, and every inpatient that's on antibiotics, we're gathering whatever information we can on those patients, and then we're sitting down and having a call with an highly trained antimicrobial stewardship pharmacist on the other end. And so we review those cases. We go through and get feedback from them, and then in turn can take that feedback to our providers. They also will sit in on our team meetings, helped us develop order sets, different things like that. But there is no doubt in my mind that it has made a difference in quality care. There's no question about that we're providing better care to our patients because of the partnership that we have with them. And in addition to that, it's just, you'll see on here, students, we get students in and we engage them, get them, hey, you're gonna gather this notes, get the data put together, have this call, and they love it. But there's enhanced provider-pharmacy collaboration, and that might come as a surprise. And I think there's two reasons for that. There is a lot of trust and value in the name, the people that we're working with, and there is also, it's not all about de-escalation. It's not all about IV to PO. It's not all about discontinuation. There are times where we'll get a recommendation, we really should start something for somebody. And it's through those interactions that we have that our providers actually, do we still come out with unsolicited advice? Yes. Do we still approach them and do I have 100% buy-in? No, we don't. But I actually have a number of providers, some key providers that come to us every day. When's the call? What are you guys getting ready to do and talk about? Let me give you some information. Let me know what they do. And so that's a win. It's a huge win for us that they're coming and they want to know. And I just can't speak enough to that in our facility. But they're there at any point in time. We can reach out, and so I just think it's been really nice. There was a question as I was putting this together, how did I empower staff? I don't think any of this is groundbreaking by any means whatsoever, but job descriptions, when we put it in there, they were fully aware that this is going into, hey, you're going to be responsible for some stewardship activities, and I think we're going to start these calls. And initially, I led those calls, and we've got a pretty competitive group. Anything you can do, I can do better kind of thing. So as we're listening and sitting in on theirs, it's like pretty soon, can I do the call? Can I gather this information? I want to be involved in that. And then the goals. We have, and I'm sure others out there have the same thing as far as your annual performance appraisal, things like that, but we have an annual goal, several goals that we work on, and so I made sure to encourage it. Get your certification, okay? What other things can you do for stewardship that we can incorporate into this? And so then there's a financial incentive tied to that they want to definitely work towards. I debated about putting these slides in. Jenna told me I needed at least 5 slides, so they got thrown in there as filler, but actually they kind of speak to, the main talking point on these are what we call quality boards, and it's part of how we get the message out to not just the staff, but the providers and the patients that come into the hospital about some of the activities that our stewardship program is doing. And so it's a big board posted right in our front entrance of the hospital. Everybody sees it every day. They walk down the hallway, and they can see the difference that stewardship is making. And so it's kind of impactful, I think, even through the community, just getting that messaging out. There's another example of one of them that we worked on. And then this last slide, this was a news release that got put out after we learned that we were the first critical access hospital in the state to start submitting AR and AU data. After hearing Dr. Ashraf's talk, I kind of was thinking maybe we should have held off a little bit to get reimbursement for that, but doesn't hurt to be an early adopter. But we put this out there and just to celebrate when we heard that we were the first, we wanted to celebrate. I believe, though, that this may have been the reason that I landed up here today, so be careful what you celebrate, and if that's the main takeaway, that's what I'll leave it with, so that's it. Thank you.
All right, we're over time. My iPad in front of me is very red and angry, so I apologize. I'll just leave you with the last couple of slides there in the packet for additional strategies that we brainstormed as a team for increasing pharmacist involvement in stewardship. Just want to wrap up by thanking everyone for coming today, thanking all of my team for helping put this together. I think it was a very educational and impactful day. I guess UNMC is wanting your things back for your name badge, so there's a bucket out there if you would like to leave them for them to reuse. And the information for your continuing education came out in your email from Tori yesterday, I believe. They'll be sending a reminder email, but she said you only have 20 days to get your continuing education credits claimed. So just make sure you do that. And I hope everyone has a safe trip home and hope to see you next year. Thanks.